Everybody knows Marc. Marc, you're one of the doctors for this department. We really appreciate it a lot. Marc's going to talk to us about arrhythmogenic mitral valve prolapse, which is something we should be aware of because it's a relatively new. It's an old phenomenon that has been recently recognized and described, I would say. So Marc, come up and teach us about it.
Oh, I brought up right. We'll get back to the meaning of this picture in a few. This is arrhythmic mitral valve prolapse, and we're going to go over some case examples, background, the incidence of mitral valve prolapse and its relationship to sudden death, some characteristics of high-risk patients, proposed mechanisms, possible interventions, and risk stratification. So this is case number one. This is a 51-year-old female. She's got long-standing mitral valve prolapse. She was asymptomatic. In 2011, she had a routine EKG at her doctor's office, and she had occasional PVCs. They looked like they were probably papillary muscle based on the origin. In 2015, she has a routine echo. It demonstrates moderate mitral valve prolapse with from the posterior leaflet, moderate MR and EF of 70%. Still asymptomatic, so they're watching. In November 2016, she calls her cardiologist's office, and she reports occasional dizzy spells, but she denies any syncope. Later on that month, she's running on a treadmill at home on a Sunday morning. She suddenly collapses. EMS arrives, defibrillates her 3 times for what they describe as ventricular fibrillation. She gets intubated, hypothermia protocol, and she survives with intact. She undergoes a single-chamber ICD implant for secondary prevention, and she has no sustained VT-VF episodes for the subsequent 18 months. This is case number 2, which is from the operating room here. This is a 63-year-old female, past medical history of mitral valve prolapse. It's bi-leaflet. She's got severe MR, paroxysmal AF, and preserved LV function. And she also reports occasional asymptomatic PVCs, which are also seen on her EKG. Other relevant history includes she had an episode, she says, of cardiac arrest during induction of anesthesia 20 years prior for an ectopic pregnancy, and since then has had no cardiac events. This is her baseline pre-op EKG. You can see it's sinus rhythm with occasional PVCs. It's probably outflow tract PVCs based on the morphology. So she presents for mitral valve repair. She gets an epibolus just prior to induction. She's intubated without difficulty. She develops frequent PVCs on telemetry, followed by sustained episodes of VF. And she gets defibrillated multiple times along with CPR, and surgery is deferred at that time. So she has a workup done, which is obviously more extensive than this, but importantly, she had a coronary angiogram and showed normal coronaries with no coronary vasospasm on testing, provocative testing. She has a cardiac MRI, and what they notice is that she's got focal scar on the tip of the papillary muscle, the posterior medial papillary muscle. She's also got moderate to severe LV dysfunction, which a few months later normalized. So the question is, why did these patients have cardiac arrest? One had it at home, one had it in the operating room. And in order to have cardiac arrest or ventricular fibrillation, you essentially need 3 events to occur. You need a substrate, a trigger, and an inciting event or a transient event. So this is just an algorithm I put together for ventricular fibrillation or sudden cardiac death. So you do, as I mentioned, you need an anatomical substrate. In her, it would be an example of a myocardial scar. So she's got a little bit of delayed enhancement in the papillary muscle. You need an arrhythmic mechanism, so you need triggered activity or automaticity to trigger the event. In her, she has PVCs. And then you need something to happen on that particular day, whether it's the treadmill or the operating room, to actually induce the VF. And what you're left with is essentially what's PVC-induced VF. So a little bit of background on mitral valve prolapse as I understand it. Mitral valve prolapse is common, 2 to 3% of the general population, and about 8 million people in the US have it. It is associated, as you know, with mitral regurgitation, endocarditis, heart failure, and sudden cardiac death, which is probably the least recognized risk factor. A little bit about sudden cardiac death and mitral valve prolapse. It's very anxiety-provoking to think about. Imagine if you're a 50-year-old female and someone tells you you're at risk for sudden death. It's an uncommon event with a devastating outcome. And so the question is, are we overestimating the risk of sudden cardiac death, or are we underestimating the risk of sudden cardiac death? Can we identify the higher risk patients? Which patients and physicians can we reassure? And obviously it doesn't happen that, as you know, a lot of patients with mitral valve prolapse seem to have anxiety disorder. So tell them that at the end of an office visit. So this is something I pulled off the internet. This is one of these doctor websites in which they asked the question, can mitral valve prolapse cause sudden death? It got 4.47 out of 5. And what he said is, if you have mitral valve prolapse, I really wouldn't advise you spend time worrying about dropping dead, because you're not really at increased risk compared to someone without mitral valve prolapse. And then the answer is possibly, but it's not likely worth thinking about. So this is something Rafi Honickman said last week, right before a case. He said, the next patient claims to have a rhythmic mitral valve prolapse. Is that even a real thing? Which made this talk relevant. So a little bit about the incidence of mitral valve prolapse and sudden cardiac death and the characteristics of the high-risk patients. So this was a study published many years ago, which I'm sure all of you know. This was about 240 patients with mitral valve prolapse followed over the course of 8 years, and they did pretty well. They had 88% survival. But if you dig into the numbers, the actual incidence of sudden cardiac death in this patient population, these are not flail patients, is about 2.5%. So a certain number of these patients are actually having cardiac arrest at home. So that's obviously patients with mitral valve prolapse. But what if you look at healthy patients, right? This is from a referral center. These are patients who've obviously been, segregated out to be followed. So this was published, I think, a year or two ago in JACC. This is, on the top left-hand panel, is the causes of sudden death in competitive athletes in the United States. They looked at 842 patients which were confirmed to be cardiovascular. And what they noticed is 4% of the patients, the only mechanism of sudden death they can come up with in these athletes was mitral valve prolapse. And then if you look at athletes in the UK, these are not competitive athletes, but athletes nevertheless, the incidence of sudden death due to mitral valve prolapse was about 2%. We put a lot of focus on hypertrophic cardiomyopathy and arrhythmic right ventricular dysplasia, but clearly this is also a risk factor. So then they did a community study where they looked at all the patients who had sudden cardiac death in a particular community. I think it was somewhere in Minneapolis. And what they found was of 740 odd patients, they implicated mitral valve prolapse as the only mechanism of sudden cardiac death in about 2.5% of that patient population. So it's a small number, but if you're a young female and you have sudden cardiac death at home and the cause is mitral valve prolapse, obviously it creates a lot of anxiety. And these patients were relatively healthy at baseline. So I would say there does appear to be an association between mitral valve prolapse and sudden cardiac death. However, only a minority of the patients are having a major arrhythmia. And if you think about it, there are estimated 7 million patients in the US with mitral valve prolapse. The incidence of sudden cardiac death observed over a 6-year period is 2.5%. You'd expect 29,000 deaths per year from sudden cardiac death, which is obviously not happening. So you have to look at higher risk patients. So there's clearly certain features that we should be aware of. And this is just an example of how things are looked at in the coronary world. So in the coronary world, although if you have an EF of less than 30%, your risk of sudden death is high, the vast majority of sudden deaths are actually occurring in patients with ischemic cardiomyopathy and EFs of 50%. And that's only because statistically there's many more of them. So the absolute number is higher. And this is how we used to look at things, which is we looked at it, they're either at risk or not at risk based on a certain cutoff, let's say ejection fraction for ischemic coronary disease. But in reality, we should probably be looking at these patients as a gradient of risk. There's patients who are lower risk, medium risk, higher risk, and obviously extreme risk. So this is really where mitral valve prolapse and sudden death kind of came around in the last few years. So this was published in 2013, and this kind of scared a lot of people in the EP world at least. They looked at 1,200 patients at the Mayo Clinic. They have a sudden death clinic at the Mayo Clinic, and they looked at 1,200 patients who had out-of-hospital cardiac arrest due to VT-VF documented on ECG by EMS. And after an extensive evaluation, they were able to classify everyone except for 24 patients who had unexplained out-of-hospital cardiac arrest. And that means the patients didn't have any personal history of, let's say, a channelopathy, no coronary disease, no coronary anomalies, no unknown LV dysfunction. And what they found in this patient population is about half of these patients who had unexplained out-of-hospital cardiac arrest actually had bileaflet mitral valve prolapse in their history. And then they looked a little deeper into these patients and they noticed a relatively consistent event throughout, which is, first of all, most of them had inferior T-wave inversions in the inferior leads. And a lot of these patients had a history, at least documented by Holter, of complex ventricular arrhythmias. Complex ventricular arrhythmias just means you have at least 2 morphologies of PVCs or you have couplets and triplets. So it's not sustained ventricular arrhythmias. So a few years later, a different group did an autopsy study. What they looked at patients who had sudden cardiac death and were under the age of 40. So they're looking at a relatively healthy patient population, well, who's now passed away, unfortunately. And they found that 7% of this patient population they thought were related to mitral valve prolapse based on autopsy. And what they found in these mitral valve prolapse patients, 60% were female, so a majority were female. And a majority had, again, these negative or biphasic T waves in the inferior leads. 100% of them had some history of complex ventricular arrhythmias by Holter. And 100% had fibrosis of either the papillary muscles or the basal LV. So there's a relatively consistent kind of pathology throughout all these patients. And the question comes up is why? Why are these patients having sudden death, and why do they have all these findings of these at-risk patients? So the first question is, why does a patient with mitral valve prolapse develop left ventricular fibrosis? So this is just histology of a normal patient, and this is a patient with mitral valve prolapse. And what you notice here is they get this kind of displacement of the mitral annular junction. And the thought is that all of this pulling on the mitral annulus and on the LV is actually causing stretch-induced fibrosis. And someone looked at, this was actually published a couple of days ago as well as a couple of years ago, which is they looked at patients with mitral valve prolapse and they noticed a consistent finding in those who had fibrosis. And there's this concept called mitral annular disjunction, which is the mitral valve actually gets almost pulled away from the left ventricle because it's being exposed to these forces all the time. And when you look, the patients with fibrosis had much more displacement than those without fibrosis. So the thought is that this is all stretch-induced fibrosis. Not a lot of these patients get an MRI, so the question is, can you actually look at an echo to see if patients are more likely to have fibrosis rather than sending them for an MRI? So anyone knows history, this is called a Pickelhaube. This is a helmet from World War I that the Germans used to wear. And what happens is if you do a tissue Doppler of the mitral annulus, the lateral mitral annulus, what you see is these high velocity spikes on the mitral inflow, on the lateral tissue Doppler. And it almost looks like this little helmet, I guess. And what they looked at is they called high velocity anything over 16, and they saw that anyone who had over 16 was more likely to have fibrosis and complex ventricular arrhythmias. So it might be a nice screening exam is that if you do an echo just to look at the tissue Doppler characteristics of the patient, and that can tell you if they're more likely to have a scar and whether or not they should get an MRI to be risk stratified. So that takes care of the substrate, which is thought to be, as I said, stretch-induced. But why do they have triggers? So this is an example of the left ventricle. Here's the papillary muscles, anterolateral, posteromedial. I hope I'm correct on that. And as everyone knows, there's a His-Purkinje system. The His-Purkinje system are fibers that run along the septum and then go into the ventricle. It's how we conduct impulses from the atrium to the ventricle. And the ends of the His-Purkinje system are actually in the papillary muscle. And we know that if you touch any form of the His-Purkinje system, you can cause ectopy. And the thought is that actually all the stretch on these papillary muscles is the triggers that you're seeing on the EKGs. So this is an example of a patient who has what looks like papillary muscle PVCs. They're relatively short coupled, and you can see what happens is that if it falls a few milliseconds earlier, it induces non-sustained VF. And so the trigger is probably, again, also stretch-induced. So back to our patient, this is case number 2. This is the woman who died on the table. She's a female. She has bileaflet prolapse. She has T-wave changes in her inferior leads. She's got known ventricular arrhythmias. She's got echo evidence of mechanical traction on the mitral valve. This is actually her echo done in the CT ICU afterwards. This is her positive Pickelhaube sign. She's got an MRI showing scar in the papillary muscle, so she has substrate. So that explains why she was relatively high risk for this event, but it doesn't explain why she had the event on the table that day. So if you look at the third component of what's necessary to induce cardiac arrest, you have to have some kind of transient initiating event. So in this particular patient, the question is, could it have been catecholamine related? And if so, why would she be more likely to develop an event after getting a small bolus of epi, which lots of patients get? So if you actually look at the mitral valve prolapse patients, this was looked at in the late 80s and early 90s of, why do they seem so anxious? Why do they always have palpitations? Why are their heart rates higher? So someone thought that they had high adrenergic tone, which is what turns out to be correct. So for unknown reasons, patients with mitral valve prolapse have higher baseline levels of epi and norepi in their blood system. If you put them on a treadmill, i.e. give them adrenergic tone, they have more PVCs than control patients or even patients with LV dysfunction. And if you give them isopril, which is a catecholamine, they have a hyper-responsiveness to an isopril infusion. So they seem to be more sensitive to epinephrine as an example. And perhaps that's the reason that you put all these 3 events together, and that's why the patient had cardiac arrest that day. So now that we know these patients, or we believe that these patients are at risk, and we believe we can identify who the higher risk cohort is. The question is, can we do anything about it? So this is the question about potential interventions. So this is a different patient. This is a patient of mine. She's a 50-year-old female. She was evaluated for palpitations. She had a Holter showing 34% free burden of PVCs. She had at least 2 different morphologies, probably outflow tract and papillary muscle, and she had a few episodes of NSVT. Her echo showed bileaflet prolapse with moderate MR and an EF of 46%. And we did a cardiac MRI on her, and she had scar in the mid-infralateral LV. This is an example of her PVCs. You can see here the right bundle in V1. They're likely coming from the left ventricle, and they're likely coming from roughly that region where the scar is. So for her, the question is, can we remove one of these 3 events and reduce her risk of sudden cardiac death? So for her, we actually offered her a catheter ablation. We didn't offer a catheter ablation to reduce her risk of sudden death. We offered her a catheter ablation because our concern was that she had a PVC-mediated cardiomyopathy. So this is an example. This is an activation map of the left ventricle. This is the papillary muscle. This is the left ventricle. The colors just indicate timing from our catheter. And we performed ablation at 2 separate areas. And if you look at her EKG in all her office follow-up, she doesn't have any residual PVCs. So that portion of the procedure was effective. The question is whether or not we actually modified her overall risk. She's still a female. She still has bileaflet prolapse. She still has the abnormal T wave. She still has the Pickelhope sign, and she still has myocardial scar. So the answer is that we probably reduced her risk to some degree, but we didn't mitigate it. And when it comes to sudden cardiac death, you either mitigate the risk or not. There's no in between. What we do know is that patients who've had ICDs put in for either primary or secondary prevention and have ventricular arrhythmias such as ICD shocks or ATPs, that if you do a catheter ablation targeting that trigger, that you'll reduce their risk of subsequent shocks. But there is a recurrence rate, so it would not be enough just to say we offered her a catheter ablation. So she's actually at some point coming for an ICD implant, and probably eventually mitral valve surgery. What are the effects of mitral valve surgery on ventricular arrhythmias? There's even more limited data on this. The largest case series I could find is about 5 patients, and all they and this, by the way, does not apply to flail patients. All they showed is that you can reduce their risk of subsequent ICD therapies and follow-up. So again, it's effective, but it's not effective enough if you think they're at higher risk. So what about the concept of EP study for risk stratification? This was done in the late 80s and early 90s. A lot of these patients, when EP studies were a hot topic, they were getting EP studies. So the problem with an EP study in any disease process is that an EP study tends to be quite non-specific, meaning I could put myself on the table and I can induce VF in myself if I wanted to. I gave myself an ICD, but a majority of them were actually inducible for polymorphic VT-VF, which is not a very specific finding in any disease process. And having said that, the reason what I would say is that if a patient is deemed to be higher risk, so they have 3 or 4 of these major risk factors, then I think you're warranted in doing EP study for risk stratification. But how you interpret the results matters more than anything else. By the way, VES stands for ventricular extra stimuli. The more you put in and the tighter the coupling interval, the more likely you'll induce an arrhythmia. So what I would say is that if you did 3 ventricular extra stimuli, which is considered a normal EP study, and you induce monomorphic VT, I would call that a positive EP study for this patient. Or if you induce polymorphic VT or VF with 1 or 2 ventricular extra stimuli. It's very uncommon to be able to induce VF in somebody with just 2 extra stimuli. So these are the criteria that I use for positive EP study in mitral valve prolapse patients. So in my conclusion, most patients with mitral valve prolapse have a benign prognosis, but there's a recognizable subset of patients that develop major complications. Patients should be evaluated for high-risk features since sudden cardiac death is more likely to occur when these features are present, when you have evidence of stretch and contact-induced fibrotic changes by MRI, if you have mechanically triggered PVCs, especially if you have more than 1 morphology, if you have bileaflet prolapse, and if you're young and female. A reasonable workup would, of course, be a Holter monitor, an echocardiogram, and consideration of MRI. The estimated risk of sudden cardiac death ranges from 0.1 to 1.9%, depending on which study you're looking at. And despite these risk estimates, current guidelines do not address mitral valve prolapse in any form or fashion. EP has a new sudden cardiac death guideline coming out every 2 years, and mitral valve prolapse is never mentioned in there other than one sentence which says these patients are at risk. You should consider EP studies for high-risk features. Precautions should be taken for those with high-risk features. This is something I didn't know, but if you have any of these high-risk features with mitral valve prolapse, you are not supposed to engage in high-intensity sports. And you have to be careful in the perioperative period, especially if you're going to give them catecholamines. And interventions targeting the mechanical traction or the trigger will likely reduce the overall risk, but not mitigate it. So this is actually a picture or a drawing from a play in the 1890s called the Tales of Hoffmann. And a few people wrote editorials that the main character in this particular play actually died of mitral valve prolapse related sudden death. And they base this on the fact that as she's singing, she drops dead, that the cadence is along with her pulse, which is irregular. So that's the thought. That's where it comes from. Thank you.